presentation. I have a true distinct pleasure and honor to introduce John Yue. John Yue is a first year attending at UCSF in whose primary appointment is at Zuckerberg General Hospital, which is the trauma center at UCSF. But I think saying John is a first year attending is just doesn't do service to the impact he's already had on neurotrauma. John was a clinical research coordinator who then went to medical school at UCSF and then pursued a residency in neurosurgery at UCSF and has always been very interested in neurotrauma, has won I've never met someone who's won as many awards from the joint section of neurotrauma and critical care as John. He's won numerous NATIS awards. He's won the NREF grant, the Marmaru Award, and just recently is the second annual SOFISA Award winner. I've been very lucky to know John over the years and collaborate with him through the Track TBI network. I don't know any first year attending who has an H index of 58, but it just belies the depth and breadth of his investigation in traumatic brain injury and also traumatic spinal cord injury, and particularly his focus is on blood-based biomarkers. So I thought this would be he would just be an amazing speaker to articulate what the role of blood-based biomarkers in traumatic brain injury is. As we know, the industry has come into the space, and we have been able to validate the Abbott iStat test for detection of GFAP and UCHL1 in patients with mild traumatic brain injury. But more importantly, where are we going? How do we use these biomarkers to establish prognosis and recovery projections? So we're very lucky to have John, and I'll let you take it away. Thank you so much for joining us.
Great. Well, thank you very much, Ramesh, for the wonderful introduction and the kind invitation. My name's John Yue. As Ramesh said, I'm an assistant professor of neurologic surgery at UCSF and San Francisco General Hospital, as well as a co-investigator on the Track TBI consortium. I've had the pleasure of working with Ramesh and many others over the last 16 years of time in neurotrauma. And I think that this is a very exciting time, as Ramesh alluded to, of numerous kind of upstream and downstream improvements in understanding of blood-based biomarkers and how they can be used to improve diagnosis, improve injury classification, and improve prognosis and prognostication and understanding of outcomes in traumatic brain injury patients, both in the acute term within the hospital, as well as the subacute and long-term trajectories of recovery. I'll be talking about blood-based biomarkers in TBI, and also giving kind of a roadmap and history of what has happened over the last 15 years that has brought us to this place, and where we are moving forward from here, which is incredibly exciting and opens up many opportunities for collaboration. So here are my disclosures from NREF and from the UCSF Weill Institute. And these numbers are old now, not unfamiliar to anybody in the room here, but incidence of traumatic brain injury, probably actually close to 5 million people a year in the United States. The 1.7 is an older number from the CDC. The more current numbers, I think, are 2 to 3 million. And it doesn't account for the people that don't come in because they're on the field or, pediatrics or happen in the outpatient setting and never make it to the emergency department. The direct and indirect costs are upwards of $85 billion annually in the US alone. And there's a bimodal distribution of injury, both in the younger adults, usually the younger adult males, as well as the older adults, greater than ages of 65 and beyond, due to incidental falls, and in the setting of higher comorbidities. And these numbers here on the right are a little bit older, from 10 years ago, but it kind of represents a trend where The number of deaths are decreasing from traumatic brain injury here in the United States. However, the number of ER visits are increasing. And is that because we're having way more TBIs? No, it's because people are becoming more health conscious. Our detection methods are improving, technology is improving, awareness is improving, and thus more people are visiting the emergency department seeking care. Now, how do we take better care of people without overloading the healthcare system? I think that's a really important problem with a certain number of solutions, which includes blood-based biomarkers, as you'll see shortly here. So traumatic brain injury, as you guys know, can be coup contra coup, can be rotational, can be direct impact, and those things lead to direct injuries, extraaxial hemorrhages, contusions, as well as rotational exterior injuries, traumatic microvascular injuries, and DAI. None of which, in the latter category, show up too well on CTs. However, are better seen on MRIs and lead to profound outcomes impacts with a lot of poor outcomes from axonal injuries. Yet without an MRI, we can't see that very well in the brain. So is there a way of not ordering an MRI on everybody that comes in the ER with some mild deficits and whatnot? But have a better way of detecting subtle injuries that occur in traumatic brain injury that don't maybe need hospital admission, but need someone to monitor them and follow up with them to improve their symptomatology, monitor their symptomatology, and decrease the chance of repeat injuries. Well, I think you'll find that blood-based biomarkers may be a partial solution to that as well. So we're going to move forward. Historical challenges, no neuroprotectants from existing clinical trials in traumatic brain injury. Calcium channel blockers, glutamate antagonists, steroids, hypothermia, progesterone have not shown conclusive evidence of benefit, although some of this is used in an off-label fashion. And I think, studies, at least RCTs and large, very large amalgamations of clinical trials have failed to show results from these interventional trials because of a couple of main issues. Number one is inclusion of a very heterogeneous population with multiple intracranial injury types, extracranial injury types, severities, lesion volumes, lesion locations, lesion eloquence, etc., as well as comorbidities and differences in variable collection, differences in stratification, and therefore combining a very heterogeneous group of patients that have different lesion types, locations, volumes, comorbidity profiles, and treatment plans across institutions will lead to differences in outcomes, as we know. And dichotomizing an outcome into good or bad after traumatic brain injury, the most complex injury in the most complex organ of the body, it, that's kind of challenging. And what is good and what is bad? Well, some of it's hinged on the initial nature of the injury and injury severity. For instance, somebody with a bad multifocal brain injury, GCS3, brainstem BAI, and bilateral mass lesions, the outcome of that person, if they are able to move around the community at all, is probably, good in relationship to the injury. However, a patient who has a GCS 13 to 15 injury that is discharged from the ER without a mass lesion with a CT occult MRI positive injury in the non-dominant frontotemporal region, that person may not ever be in the care system, but we know that that person may suffer outcomes that impact their return to work potentially. And even though they're able to move around the community and go back to partial work, that would be a poorer outcome for the level of injury of that person. So there needs to be better classification systems, risk stratification systems, clinical severity stratification systems for inclusion in clinical trials, and a more sensitive approach to multidimensional outcomes that is both in relation to the initial severity of the injury and other personalized factors of the patient, so we can better understand what outcomes result from what types of injuries and how these outcomes recover over time. The still the only FDA cleared outcome measure for traumatic brain injury is the Glasgow Outcome Scale Extended, which is an 8-point scale of functional outcomes ranging from dead to back to baseline. As you can see, 1 is dead, 2 is vegetative. Three is lower severe disability, so they need help with their activities of daily living. Four is upper severe disability, so they can do some to all of their ADLs, but can't really move around the community to their full capacity. Lower moderate, they can move around the community, but can't go back to work. Upper moderate, they can go back to work at a reduced capacity. Lower good recovery, they're back to work, but with mild, what we call classically post-concussive symptoms. And upper good recovery is back to baseline. The cut point between bad and good, or unfavorable and favorable, if you look at the literature, is 1 to 4 versus 5 to 8. Now, depending on how you stratified the patients and which kind of patients you included, that may not be appropriate for the types of injuries that you're looking for. And it severely reduces, the sensitivity of detection of your outcome measure to what is actually happening with the patient. If you're going from, dead to not going back to work versus going back to work with significant symptoms, versus actually recovering back to baseline. So there needs to be a tiered approach to outcomes. The current approach to TBI classification, everyone knows the GCS, but as we found, the motor scale or the motor subscore of TBI and GCS is actually more predictive of outcomes than the other two, and thus has been included in numerous outcome prediction models. And we'll see a little bit more of why that is. Acute intracranial findings on CT, obviously, with rapid acquisition and lack of contraindications is the best way, but as we've said before, lesion type, location, volume, eloquence, progression, all matter both locally and in the brain in terms of mass effect, midline shift, and herniation. And how we quantify that in traumatic brain injury studies going forward is going to be important on the relevance of the outcomes and the accuracy and precision of the outcomes to the types of injury people are having. And how do we use blood-based biomarkers in 3T MRI? Well, we'll see here. So I'm going to breeze through this. This is the last 16 years of data standardization from missives from the National Institute of Health. We've shown that we can standardize data based on the TBI common data elements across the large domains of demographic and clinical information, blood-based biomarkers, so plasma and DNA, neuroimaging, which is CT and 3T MRI, and outcomes. And this is multidimensional outcomes. You can see here on the right, global outcome, neuropsychological impairment, mental health, post-concussive symptoms, social participation, quality of life, etc. So this is back in 2010 to 2012 when we had the Track TBI pilot project, and we showed that we can establish data standards and evaluate the feasibility and utility of implementation of these data standards in traumatic brain injury. And this really set the background to how much we've been successful with the Track TBI Consortium, the Center TBI Consortium, and others over the last 10 years. And many of which that Dr. Grandi has been a co-investigator of as well. And it's really through establishing data standards across all of these large domains of data that has allowed us to, be able to pool data across many large institutions, many large studies, to achieve a power sample that is statistically robust enough with the data captured all in the same way, with the same definitions and the same data dictionary, to empower, conclusions rather than silos of data that have been, that are published but perhaps can't be replicated. So, we did this in the pilot study from 2010 to 2012, looking at, all of the baseline demographic and acute injury and comorbidity variables, blood draw variables within 24 hours of injury for both plasma and DNA, 3T MRI within 2 weeks of injury, 3-month outcomes, 6-month outcomes, 12-month outcomes. For the next iterations, the 18 center track TBI study in the US that was done from 2014 to 2018, we added 2-week outcomes in addition. And we looked at longitudinal outcomes from 2 years, 3 years, all the way out to, close to 10 years now and beyond, for a truly, study of the life course of traumatic brain injury, as a chronic disease, as well as an acute injury. So that's really exciting. We built a data warehouse to house the data, which is still currently in use. We've published probably, 50 to 60 papers from the Track TBI pilot study alone, across all of these domains. So what did we find? Certainly data standardization was feasible and implementable and had utility. in driving, the reality of accurate conclusions that empower the next generation of clinical trials and understanding of traumatic brain injury outcomes. So, I'll take us through a little bit of why imaging and biomarkers are tied together. This is back in 2013. This is the first paper that came out of the TRACK-TBI study. We looked at GCS 13 to 15 patients who had a normal admission head CT and an abnormal early MRI at 2 weeks post injury. And what we found is that 25% of the patients with negative head CTs had findings on their MRI. And what were they? Well, they're small contusions and axonal injury or traumatic microvascular injuries now by the NINDS that aren't readily seen, as everyone knows here who's looked at a head CT in neurosurgery. So, but these patients actually have lesions in their head, right? And they're, it's a big difference of being told that there is no injury on your head CT to there's actually, CT or MRI positive lesions or neuroimaging positive lesions. And this has follow-up implications. It has disability implications. It has insurance indications and implications across all of these things, and certainly for follow-up and for recovery. So, being told that you have something in your brain versus you don't in terms of injury is going to be really important. And again, 25 to 30% of patients for CT negative GCS 13 to 15 have lesions on their MRI. So that's not an insignificant number. That's 1/4 to 1/3, right? So, well, do they matter? Well, it seems to matter, as you can see here on MRI, these are all normal head CTs, but on MRIs, there's small dots of intraventricular hemorrhage, axonal shear, small contusions, et cetera. And certainly you can't see them very well on CT, but especially if it's in an eloquent region or in a network heavy region, it's going to lead to, functional deficits potentially. And being told that you have a lesion that's causing your problems versus, well, your head CT was negative, you don't have a TBI, and you're having these symptoms, well, that's a big difference for people in terms of understanding and follow up and, kind of risk stratification and the risk avoidance, and just basically, taking better care of themselves over time, right? And what do we find? Well, subarachnoid hemorrhage is predictor for poor 3 month outcomes. Contusions and axonal injuries are predictors of poor outcomes, and we'll kind of see why in the future here. So, moving forward, these are studies on biomarkers over the last, 10 to 15 years now, by Dr. Okonkwo back in 2013. We looked at glial fibrillary acidic protein in the blood. And, as you can see, the CT positive people have this astrocytic protein that are leaked from damage or more permeable blood-brain barrier into the systemic circulation. So you draw those within 24 hours. And yes, GFAP is higher when you're CT positive. It's higher when you have more lesions. It's higher in more severe TBI. And with Kevin Wang and the University of Florida now at Morehouse University Group, looking at autoantibodies, we also found that patients with prior TBI or a history of TBI also have autoantibodies to TBI. Now, where do those autoantibodies go? And when they bind to the GFAP, what happens, right? Is there an immune reaction that's circulated or that's engendered with downstream effects? And where does that happen? Does that happen intracranially? Does that happen systemically? And is there a chronic inflammation hypothesis or a neurodegenerative hypothesis linked to prior brain injury? We've always thought so, but I think this is an area of current investigation that's very, very exciting. We also looked at tau, which is a neurodegenerative marker. And yes, tau correlates with both acute brain injury as well as chronic brain injury. You can see here on the ROC curves here on the right, the AUC for tau, which is phosphorylated tau in this case, is actually quite good for detecting acute brain injury with the positive head CT. And in chronic brain injury or patients with a history of TBI, these are patients who required admission to an acute rehab center back in our attractive TBI pilot study. The AUC was 100%. So there's definitely some link between neurodegeneration chronically and traumatic brain injury, right? And that's not a surprise to anybody because you have brain injury, you have encephalomalacia, you have loss of function of those neurons or those networks, yeah, it's going to lead to more neurodegeneration. But there are biological correlates that we can detect that merges with the neurodegenerative Alzheimer's and dementia literature here. So, in moving forward, I think some people at least are familiar with our 18 center track TBI consortium here in the United States, and that's expanding actually to more sites than just 18. These are 18 level one trauma centers where we use the NIH common data elements and enrolled about 3,000 patients here in the United States, as well as concurrently 7,000 patients in the European Union in our sister study, the Center TBI study, conducted over the same period of time using the same variable. So we really had a power sample of about 10,000 patients with the variables across the domains of data that we had discussed earlier to empower probably the next 100 to 200 papers and beyond in traumatic brain injury and neurotrauma that's led to a number of exciting developments that we'll go through. So here, this is one of the largest studies that looked at CT findings after GCS 13 to 15 traumatic brain injury from track TBI here in the US with external validation, center TBI across I think, 60 centers and institutions in Europe. There were a total of many thousands of GCS 13 to 15 patients. As you can see, these the lesion types do matter, right? Epidural hematoma, subdural hematoma, contusion, subarachnoid hemorrhage, intraventricular hemorrhage, and petechial hemorrhage, which is associated with gliding contusions and shear injuries. They can all be present in GCS 13 to 15 TBI, but how people recover from them and the management plans are very different. Epidural hematoma, you're going to observe it, you can probably take it out, and people tend to do better after those. Subdural hematomas, you can observe them, you can take it out. They do a little bit less good as the epidural hematomas if you evacuate it. Contusions you usually don't take out, but probably have to monitor for some time and make sure that they don't bloom and expand and cause further deficits and shift. Subarachnoid hemorrhage, no way of taking it out, but is correlated with a bunch of bad outcomes. Why? We'll see in a little bit. Intraventricular hemorrhage, a indicator of deep injury and deep rotational shear. Can you take it out? Well, no, but if it gets worse, do you need an EVD? Well, maybe, I don't know, but certainly worth observing. And petechial hemorrhages, they're usually at the Great White Junction and linked to functional networks, even though they're never going to need surgery, they're going to need some sort of follow-up, right? So as you can see here in the upset plots here, tract TBI and center TBI, respectively, isolated subarachnoid hemorrhage was actually the most common injury in this cohort. Well, we know that isolated subarachnoid hemorrhage, as you can see here in the multivariate outcomes plots here, along with contusions and subdural hematoma, lead to poor outcomes across the board: 2 weeks, 3 months, 6 months, and 12 months. Epidural hematomas, actually are associated with less poor outcomes at 6 months and 12 months. So, and of course, with age, with years of education, some of these are protective factors, right? Um, but what makes certain lesion types correlate with poor outcomes? And can we detect these lesions better or in a more comprehensive and a multifaceted fashion than just using imaging? Well, I think we'll see. So, as Dr. Grandi mentioned, this is literally probably the last 20 years of work. Back in 2018, GFAP and UCHL1, as part of the ALERT TBI trial, and I think GCS of 9 to 15 patients, was first qualified by the FDA as markers with potential value in the detection and evaluation of traumatic brain injury. And this was because GFAP and UCHL1, when combined, had a negative predictive value of 99.6% for CT positive versus CT negative lesion types, right? Which is quite good as a screening test. So, at that time, the Brain Trauma Foundation test was a plasma test that was a benchtop test. So it took results, 3 to 4 hours probably to truly result after analysis, which may not be pertinent or of high utility in the acute diagnostic timeframe. And I think this is important because we don't really think about how quickly an assay results until we use it in the clinical scenario. And however, this really paved the way for these two priority markers to be detectable in the blood and to be measured and to have value and to, kind of push forward technology into further qualification in shorter timeframes. So we'll touch upon that soon here. We've mentioned GFAP and UCHL1. GFAP is an astrocytic protein. UCHL1 is a neuronal protein. So it makes sense that if they leak across the blood-brain barrier and are detectable from a blood draw, that brain injury has occurred. And we talked about a lot about CT negative patients with positive MRI. So can we actually detect, people with positive MRIs who, have CT occult injuries? We know that GFAP and UCHL1 work well for CT, right, with a high AUC. So, can we expand the utility of their use and understand how they may better diagnose, be better for diagnostics and be better for prognostication, perhaps in the acute setting that transfers to the subacute setting and the outpatient setting, or even be used in the outpatient setting. So we looked at the tract TBI patients who are CT negative and essentially sought to replicate our study from tract TBI pilot. And we also looked at orthopedic controls and healthy controls, which were enrolled in tract TBI. So the ortho controls did not have any brain injury, but had a extracranial injury. That was an AIS, abbreviated injury scale for an extracranial body part of 3 or above. And healthy controls were actually enrolled as part of friends or family members of patients that were enrolled in Track TBI because the thought is that people who come from the same community are probably more alike. And we screened them for pre-existing conditions as well and excluded people with prior head injury and major systemic injuries accordingly. And all blood was drawn within 0 to 24 hours of a traumatic brain injury. And here was analyzed using prototype immunoassays that are no longer prototype because they are, approved for clinical use by the FDA in plasma assays that resulted within 15 minutes rather than 3 to 4 hours. So this was our study from back in 2019 looking at CT negative patients. And what we found is that GFAP actually has an AUC of 0.85, as you can see on the middle plot there, when drawn within 9 to 16 hours of injury for CT occult MRI injuries, right? And this is pretty profound because previously, these injuries would only be detectable on an MRI. And, an MRI has a number of contraindications. They're expensive and they're long. And it's hard to get a patient in, and certainly challenging to get a patient in during the acute setting, especially if that patient doesn't need, a lot of the benchmark measures here are neurosurgery intervention. But neurosurgery intervention has traditionally been thought about as neurosurgical procedural intervention, such as surgery or, intracranial neuromonitoring. There's a lot of neurosurgical or neurological interventions that we do, AEDs, neurochecks, fluids, right, sodium management, et cetera, that aren't included in the traditional definition of neurosurgical intervention. So I think here, this is kind of within the same vein. Are there better diagnostic methods that can empower us to understand who is going to perhaps have lesions, have intracranial injuries, and do poor on outcomes? Well, GFAP is one of those things, right? The overall AUC is 0.78, which is pretty good for an acute biomarker that can be, drawn, very quickly and the results within 15 minutes. That can potentially tell you if somebody has a CT occult lesion. And as we can see here on the right, with these box plots, diffuse axonal injury, something that can't be seen readily on CT at all, correlates very well with GFAP, right? So can this be a marker for DAI? Well, I think we need more studies, but I think that this is showing us that it possibly could be. And in looking at the median values of GFAP here, in CT positive patients, the median is 800. In CT negative patients, the median is 100. In CT negative MR positive patients, the median is actually 400. And in CT negative MR negative patients, the median is 74. So is there a severity claim to GFAP? I think, we've shown that there is. And it's not just based on CT, it's based on the overall aggregate intracranial injury, right? That's leading to this marker being leaked into the bloodstream. So that's important. And as you can see from the ortho controls and the healthy controls, the median's 13 and 8. So it can definitely be used in a responsible and thoughtful fashion with validation studies in terms of cutoffs. And how do we draw different cutoffs that lead to different risk stratifications of the likelihood of acute injury that needs ICU, that needs inpatient admission, that needs, perhaps observation and correlates with a neurological exam. It needs, anticipatory guidance. It needs referrals to a primary care physician. It needs referrals to a patient who's well versed in neurotrauma. Like these are all good questions for the future because they have disability insurance follow up, risk prevention ties, and these are all economic ties that affect the $85 billion of direct and indirect costs of TBI annually in the United States. So it's worthwhile to think about. And here, this is a graph from one of Kevin Wang's studies from the past, where it shows there's multiple different types of biomarkers, right? There's neuronal biomarkers that are released in the blood very quickly, such as UCHL1. There's glial markers such as GFAP that are released over the course of hours and decline over the course of days. There's neurodegenerative markers that rise over days to weeks. There's apoptotic and demyelinating markers that arise even longer than that, and there's autoimmune markers that arise in the chronic time frame. So what types of biomarkers you measure, when you measure them, understanding how they rise and fall in the systemic circulation in accordance to the injury, both intracranially and systemically, and what you're correlating them to along the injury time frame. Those are all important questions to designing a responsible study using blood-based biomarkers of any form in traumatic brain injury. Are you measuring and improving the diagnosis of primary injury, of secondary brain injury, of inflammatory, occurrences, right? Or of, poorer outcomes from chronic neurodegeneration. So proper application of the right biomarker in the right study to detect the right type of injury and or outcome is going to be important. And we're going to move on here. So this is a study from Fred Corley at University of Michigan, which is great because it kind of set the underpinnings of uh, these blood-based biomarkers in relationship to severity and structural injury, right? Just using the biomarker GFAP and UCHL1 alone, as you can see, the AUCs in patients with all TBI, close to zero point 0.9, right? For mortality and unfavorable outcome when drawn in an acute setting within 24 hours, that's pretty good for just a single variable. Of course, it's a little bit lower in GCS of 13 to 15 patients than it is in GCS of 3 to 12 patients because there's likely a correlate with injury severity and structural and the extent of structural injury. Now, I I want to say that these markers, they are objective markers of intracranial injuries, likely intracranial injuries of any type. We've found that these markers are elevated in stroke. GFAP and UCHL1 are elevated in smaller studies in the tumor literature to levels that are actually much higher than the neurotrauma. And these are not, uh, these are not surprising, I think, is because these are markers of structural, integrity in the brain, and damage to the structural integrity of the brain will lead to these markers being detectable, right? So, where the lesion happens and how bad is that lesion initially, and how it evolves, and what treatments are done for these lesions in aggregate, those all matter for outcomes. And blood-based biomarkers alone doesn't supplant that. So we have to be really careful about how we use blood-based biomarkers. It's not to take the place of a number of other things. It's used adjunctively as part of the armamentarium for diagnostics and in relation to that to prognostication of TBI. In the same way that I think an EKG, a TTE, a BNP, a troponin, electrolytes, et cetera, are used together for diagnosis of acute coronary syndrome versus heart failure versus something else, right? It's a multifaceted approach to diagnosis and prognostication in which biomarkers are one tool. So moving forward, this is now in 2021 and 2023, where the device that I just talked about, the iStat Alinity device from Abbott, and several others were qualified by the FDA to aid in the detection of traumatic brain injury, and in this case, in GCS of 13 to 15 patients, with the presumption probably that GCS of 3 to 12 patients will have neuroimaging that is confirmatory of some level of traumatic brain injury. Right, it's a GCS 13 to 15 patients who are waiting in the ER, who are waiting for a scan, who have a reasonable neurologic exam, with none to minor deficits, where people are and physicians are wondering, does this patient have a TBI, and they're waiting for a CT. Well, in these patients, I think, as you'll see, blood-based biomarkers may provide a lot of advantage, because they result in 15 to 18 minutes, while waiting for a CT can take hours in the ER and take up a bed in the ER, right? And the reason again that these blood-based biomarkers have utility in this population is because of the very high negative predictive value of greater than 98 to 99% of lesions on CT. Now, that is important for improving ED throughput and discharging patients that don't need, a ton of wait time in the ER, which has financial implications both for taking up the ER bed, for awaiting a CT scan, which costs money, awaiting for the radiologist read, which costs money and time, right? However, it's a twofold thing. They may provide information on how much aggregate injury there is in the brain, and it's going to be up to people who can appropriately counsel the patient regarding what to do with that value, right? If the GFAP value is, let's say, 50, well, that's going to be different than if the GFAP value is 300 and they have a negative head CT, right? The 300 value may prompt, a physician to say, well, hey, you're still having a little bit of amnesia, but it's stable and you have a good, and safe discharge environment. Your GFAP value is elevated, right? This elevation has been shown to correlate with uh, levels of intracranial injuries that don't need potentially surgery from neurosurgeons, but may result in symptoms, and you may benefit from follow-up. I think telling somebody that they've got the flu when they have a cough versus saying that you have nothing going on is a big difference, right? The person who's told that they have the flu, but there's no, they can get Tamiflu, or maybe they can get nothing, right? But that person still has a better understanding of their injury than somebody who's told that they don't have an injury. And I think people in general are pretty resourceful in seeking care. And this alone will help people understand, well, maybe I need some follow-up. I'm going to pay attention to my symptoms rather than, potentially having a poor recovery with very little understanding of what happened to them. So moving into some newer data on GFAP and biomarkers in general. This is data from 2024 led by Ava Puccio and Dr. Okonkwo from University of Pittsburgh, where we looked at the day 1, 3, and 5 GFAP values for patients who are admitted to the hospital, and how they correlate with basically acute findings on CT, right? And we actually tracked this out to 2 weeks. So we drew blood on day 3, 1, 3, and 5, and at 2 weeks post injury for patients who were admitted to the hospital. And we found that GFAP values on day 5 of injury had an AUC of 0.82, and on day 14 of injury had an AUC of 0.74 with acute CT findings of brain injury, right? So the utility of blood-based biomarkers extends beyond the 0 to 12 hour, 0 to 24-hour range. The 0 to 12-hour range is the current qualification by the FDA. And where this is useful is potentially on the field, or for, in the military theater, or, for patients in the outpatient or, subacute setting that come in and said, well, I fell, from, tackle football a few days ago, and I've not been feeling very well. And if you're able to draw a GFAP value and, it's high, regarding, and the cutoffs are going to they're going to have to be established for these a little bit better. But let's just say the GFAP value is 3 or 400. Well, I'm going to pay a lot closer attention to that patient and perhaps order an MRI on that patient, right? Versus the GFAP is like 50 or 10. Well, maybe you didn't have a brain injury at all, right? So how we use this responsibly is going to really be the next chapter of exciting investigations and validation studies. Moving forward here, we've talked about bring this full circle here in isolated traumatic subrectal hemorrhage. Well, you know, that's a that's an injury that never needs neurosurgical procedural intervention. But why is it correlated with poor outcomes in all of these neurotrauma studies, right? We've shown again and again and again that subarachnoid hemorrhage is a predictor of poor outcomes at 3 and 6 months and beyond. Well, we looked at here tract TBI patients who had only isolated subarachnoid hemorrhage and had a 2 week MRI. And as you can see, actually 46% of the patients with isolated traumatic subarachnoid hemorrhage on CT had additional lesions on MRIs. And what were they? They were contusions, subdural hematomas, and axonal injury, right? 46% of isolated subarachnoid hemorrhage patients had additional injuries on their MRI. Well, what were the blood-based biomarker levels? And can we detect that better, right? And it turns out that blood-based biomarkers, here GFAP namely, is actually much higher in patients with occult MRI lesions, even though they might be small, right? The patients who didn't have CT occult lesions, so only traumatic subarachnoid hemorrhage, the median GFAP level was about 230. If you had, one or two types of additional lesions on your MRI at 2 weeks, that goes up to about 700, right? So, this again shows why cutoffs are important when you're evaluating these people. Again, GFAP is elevated, it's 200. That's a little bit higher than what you would expect. And that is, that's because all these patients had traumatic subarachnoid hemorrhage, right? They were CT positive. But if you had in the CT occult lesion, it's actually much higher than that, right? And the AUC is 0.65 to 0.73 here, likely because of a small sample, about 60 patients. But this needs to be validated, and I think there's additional potential here because, as you can see, well, why are they not getting better? If you had no additional lesion at 2 weeks, just isolated subarachnoid hemorrhage, well, chances are you're not going back to full recovery because you're probably concussed or worse. But 25% of these patients recovered back to baseline at 2 weeks. Now, if you had a CT occult lesion on your MRI, then 4% recovered. One patient out of the 50 or out of the 26 patients in this group recovered to their baseline, right? 2 weeks. So at 3 months, this is now some time after a brain injury, and we know that patients with traumatic subarachnoid hemorrhage sometimes are discharged just straight from the emergency department. Oftentimes they are with a stable scan, or sometimes no scan. Now at 3 months, 12% of these patients who didn't have an additional lesion on their MRI weren't back to work, while 44% of the patients with an additional lesion on their MRI were not back to work, right? So, the additional lesions are probably what's driving the poor outcomes associated with subarachnoid hemorrhage. And subarachnoid hemorrhage is as close to the brain as you can get extraaxially without getting to the brain. So, are there contra coup injuries? Are there inflammatory injuries that are related to, the blood and subarachnoid space, irritating the cortex, etc.? That's probably a part of why some of these people don't recover well. So, are there implications for counseling? Yes. Are there implications for blood-based biomarkers to be used here? If somebody has isolated subarachnoid hemorrhage and they come in and you draw the, blood-based biomarker GFAP 600, well, you might have additional lesions. You don't need a cranie, right? You don't need an EVD, but you need follow up, right? And even if you can change the trajectory of a portion of these patients, 25% of these patients during follow up, that's a huge risk reduction and a huge economic advantage of mild TBI, right? Or previously called mild TBI, GCS 13 to 15. So and moving forward, I think wider adoption of TBI common data elements to improve uniformity and replicability, validation of these blood-based biomarkers at time frames beyond 12 to 24 hours after injury to expand their indication of use to aid in the diagnosis of structural TBI, evaluation of blood-based biomarkers across care settings and how they correlate with certain lesion types and severities and how they rise and fall in terms of biomarker trajectories and how they relate to outcome trajectories. Inflammatory markers, which we didn't talk a lot about, but how they can be useful in detecting secondary injury, both in the brain and systemically. How we can use 3T MRI most effectively and most cost efficiently. Modeling approaches in the era of AI, and prevention and awareness, and how biomarkers and all of these tools integrate together to better inform our patients and our care teams and ourselves. And I think in the last few minutes here, I'll venture a little bit forward into what we're doing currently with track TBI. So as we know, the Marshall score, the Rotterdam score, for CT are widely used historical prognostic models. Well, they're diagnostic and prognostic, but they're used mostly prognostically in terms of mortality risk at 6 months and et cetera, right? Same thing with impact and crash calculators. And these calculators have multiple tiers, but they mainly incorporate clinical variables such as your age and GCS, pupillary reactivity, which we know are prognostic, hypotension, hypoxia, Marshall-Rotterdam CT scores, evidence of, as you can see, traumatic subrectal hemorrhage, actually, yes, no, epidural hematoma, yes, no, and some laboratory values, right? Um, how can we improve these models in terms of prognosis and in terms of stratification of your risk for poor outcomes, right? As we can see, these are from prior papers here. The prognostic utility of Marshall and Rotterdam, depending on the population or the cohort that's being used, can vary widely. And these models, impact and crash, which were based on studies from basically 20 to 40 years ago, large studies, right? Impact combined, I think, 9 to 11 large TBI trials across the 1980s to the early 2000s. Crash was a little bit more recent, but this is data based on historical TBI patients undergoing historical treatment methods where we had, not poorer, but just less understanding of traumatic brain injury management techniques and outcomes, et cetera, than now. So back in 2024, we looked at how our current studies in tractive guide center TBI performed relative to the impact and crash models in terms of predicting 6 month mortality, 6 month unfavorable outcomes. And what we found here is that actually we are over predicting mortality. This is the upper left here, where the calibration line is above the actual mortality of the population. And we're accurately or adequately predicting unfavorable outcomes, right? Which is death to severe disability at 6 months. So does that mean that we are just saving more people that are not functional? No, I don't think so. I think we're globally better at taking care of people and making sure that people don't pass away from their brain injury. Now, are they getting better? Well, 6 months is not the static time point anymore for assessment of long-term outcomes after brain injury, right? We know that patients get better at 1 year, 2 years, and beyond. We've shown this in Track TBI with a paper in JAMA Neurology from Mike McRae at Milwaukee, as well as from Dr. Okonkwo's group, where patients continue to recover up to 2 years and beyond after the brain injuries, and a subset of them do better and continue to do better. So long-term outcome is not static at 6 months, and prognostication should not end at 6 months, right? Furthermore, patients who follow commands earlier, like within a week of their injury, are much more likely to not require help with their ADLs at 1 year after injury. The Pittsburgh group showed that. So these are all considerations to have when we're counseling other people, when we're counseling patients, and I think when we're reflecting amongst ourselves on what to do with patients, and that involves and requires updates in prognostic modeling and our abilities for prognostication, for understanding of risk stratification, classification of severity in traumatic brain injury, while integrating the new modalities and tools that we have, such as blood-based biomarkers. And finally, in 2025, so a little bit less than a year ago, NNDS came out with the CBIN model for improving the characterization and classification of traumatic brain injury. And this is based on numerous working groups, which I and many others have participated in to better understand and refine the approach to classification. So there's clinical, features such as your GCS, as well as post-traumatic amnesia, loss of consciousness, et cetera, that correlate with injury severity, right? As we know, there are blood-based biomarkers that are formally integrated into this framework by NNDS with diagnostic and prognostic potential to better characterize traumatic brain injury patients, TFBB, UCHA1, F100B, and others. Neuroimaging features, much more granular than just presence and absence of intracranial findings and or skull fractures. But also, is it on CT, is it on MRI, and location of volumetrics are going to be important, and modifiers here. So, injury factors, patient factors, these are your sociodemographics, comorbidities, uh, acute interventions, et cetera, socioeconomics, all of which are important to somebody's recovery. So, in integrating these variables together, the next step here is to refine and validate the priority variables within these domains, to better capture and better summarize patients who come in with traumatic brain injuries, as you can see here on the right. Um, and I think that this has actually been done in Europe recently across all of these studies. They've integrated and implemented and evaluated the utility of GFAP and UCHL1 in the ER, across Europe, mainly in France and Spain and others. And what they found is that, such as this study in the large ER, there's an annual savings of 700,000 euros. And the average savings per patient is 200 euros, right? With a reduction of 2 hours in the ER. When blood-based biomarkers are implemented for the reduction of, wait times, taking up a bed in the ER, waiting for CT reads, et cetera, with the right population, with the right counseling provided. And this is a study that just came out from our group here, where we looked at the potential of blood-based biomarkers and to detect, people who acutely decline. We looked at patients from the TRACK TBI study who had a GCS motor score of 6, so no motor score deficit upon arrival. And we looked at what percentage of them declined in the ER alone. Of course, there's some noise associated with all of this, but 3% declined in the ER alone. Um, and again, that's not unexpected, right? They came in with a GCS motor score of 6. However, in the people that declined, almost all of them went to the ICU. They all had amnesia greater than 24 hours. 72% of them had intracranial injuries on CT, but their GFAP median was 1400, in the group that declined versus the group that didn't decline, the median was 300, right? That's huge. Uh, UCHL1, the neuronal protein, median was 460 versus 170 in the group that declined versus didn't, right? People who needed procedural interventions, so classified as intracranial neuromonitoring or surgery, 39% versus 2%, right? Mortality is higher, length of stay is higher, unfavorable outcomes are much higher. And neuroworsening in the ER independently predicted neurosurgical interventions, lower discharge rate, and unfavorable outcomes of 3 and 6 months. But you can see on the chart here on the right, you know, if just looking at GFAP alone, if your GCS didn't decline in the ER, which is a 0, your median GFAP, as we talked about, was 300, right? If you decline by 1 point, it's 900. If you decline by 2 or more points, it's up in the thousands. Is there a structural severity claim? Yes, there is. I think so. And this is kind of the same thing with UCHL1. Um, I think this shows that maybe -2 and -5, like why is it lower in the -5 patients? Well, I think some of these patients are acutely intubated because they can't protect their airways. They have a neurologic deficit, and or if they got an early head CT, right? So there's some insensitivities of the GCS in these acute settings. But if you have a blood-based biomarker as an adjunct, that can really help, right? To understand if this is, let's say, drawn in the field and your GFAP is 1,000 and your UCHL1 is 500, well, that patient needs to, have a trauma team or a neurotrauma team ready for them at hospital arrival, and the CT scanner ready to figure out what is going on in their head that may potentially need ICU admission and or neurosurgical procedural intervention. And if somebody is, similarly GCS of, let's say, 3 to 8 in the field, with a GFAP and UCHL1 of less than 100 each, well, that person might have a metabolic problem, have another problem, have, be hypothermic, or some other relationship, or be on substances, or have some other reason that's maybe not acutely intracranial, and it helps triage and understand these patients better. So again, I would like to thank, everyone here that's listening. I'd like to specifically thank Dr. Grandi for inviting me, as well as the larger Track TBI team, without whom this study would not be possible and these findings would not be possible. And thank you very much for your time, and happy to take any questions.
Thanks, John. That was incredible in terms of just a review of the impact of radiological biomarkers as well as clinical blood-based biomarkers. Um, I would love to open it up to the group for questions. If anyone has questions, if you want to put it in the chat or just speak up. If I don't want to dominate, I have one question. Well, so. Um, So number one, I think this is the use of blood-based biomarkers and your specific last points of using them to extrapolate how we manage patients, both when on presentation in the ER and our resource utilization is really very interesting and dynamic. And we're just, I mean, the TBI group here knows this, but we're very lucky that come this summer, we will be one of the first academic centers in the United States to incorporate uh, the use of the Abbott iStat test for GFAP and UCHL1 in clinical practice to help inform how we can manage these folks if we, in patients with positive CT scans of the head, we're going to have an add-on test added on to the neurosurgical evaluation to help extrapolate what the blood-based biomarker profile looks like. So that should be able to help us do a better job for these patients and potentially with patients with low biomarker profile, send them home from the ER or accordingly stratify up in terms of the level of therapeutic care in terms of ICU admission or floor. Um, my question to you is something that we know, but unfortunately there's not too much time for it. How did the blood-based biomarkers integrate with a neuroinflammatory cascade? We know that there's a lot of uh, interplay between lipopolysaccharide, all of these systemic-based inflammatory cascades, as well as the neuroinflammasome. And can you just speak a little bit about that, and also what the role is of your genetics? Like we know that ApoE is a big deal in patients with ApoE expression is a big deal in patients in their recovery profiles from traumatic brain injury. So are we going to get to a day in which we do a multi-point ELISA on patients when they come in with a TBI?
Yeah, thank you for this profound question, which I think kind of sets me up for a multi-part answer here. And it actually underscores the potential for blood-based biomarkers as well as the future, potential of investigations in the near term here. I think that regarding the inflammasome question, um, I think inflammatory markers are secreted, some of them systemically initially very quickly, but most of them across the course of time. And the value for inflammatory biomarkers, personally, I think, is likely more in detection of secondary brain injuries in patients who are more inflamed that progress. And whether it's an indicator or response to injury, I think that remains to be determined. It can be both, right? We know that chronically, anyone who has an inflammatory process is worse in terms of outcomes. This is beyond brain injury. Anybody who has rheumatoid arthritis is probably not doing as well as somebody who doesn't have rheumatoid arthritis, right? Inflammatory disorders are profound in terms of altering somebody's outcome. And in somebody who's chronically inflamed, especially with neuroinflammation, but maybe even with feedback from systemic inflammation, do they progress to number one, poor functional outcomes. Number two, more rapid neurodegeneration. And number three, more neurological or systemic complications in the acute and the long term. And then I think, partially the answer is probably yes to all of those three, but we have to prove it. And then are there anti-inflammatories that can be provided? Here at UCSF or, and other places, as Dr. Grandi knows, we're doing a adaptive platform trial, and we're doing an oral RCT and looking at statins and candesartan and minocycline versus placebo in traumatic brain injury in a subset of patients. And anti-inflammatories do matter, right? if you can tamponade parts of the inflammatory process, you might be able to improve some of the outcomes in people. But this is hard to study because there's so many anti-inflammatories that act on different targets. There's a recent study in Leiden in Holland that looked at complement inhibitors and outcomes. There's a study in Egypt that's looking at anti-inflammatories in the ICU, right? So this is actually being done across multiple settings, and I think is a great direction for us to investigate with like-minded and smart people because there's so many inflammatory pathways in which we can tamponade. Finally, in the genetics question, I think your genetic profile is a risk stratification of your genetic comorbidities, right? I think that there's a ton of work that's been done on polygenic risk scores. A lot of them coming out of both Europe and Ramon Diaz-Aristia's group in University of Pennsylvania. That's fantastic, and looking at kind of your genetic risk for poorer outcomes. Now, I think in terms of implementation, how easily that's implemented in the acute term, that's going to be challenging, right? But people can get their hands on 23andMe very easily and other genetic testing, platforms very easily. So is there a role for some sort of expedited adoption of clinical use or clinical informatics, and with the right counseling structure for genetic loci of, poor recovery or susceptibility? We know dopaminergic, serotonergic, neurodegenerative circuits are all implicated. We know this from years and years of study, and how to regulate these pathways is going to be important in people who have more or less, response binding to, dopamine D2 receptors and others, right? I think we have to keep in mind that where is the best use of these tools? Is it outpatient? Is it in the community? Is it in inpatient settings? Is it in subacute settings, right? Is it for detection of primary or secondary injury or risk to poor outcome? These are all really important questions that I think we will be able to answer, in the fields in the next 5 to 10 years.
Well, that was amazing. Hopefully, we'll be able to answer that with you, with all of your hard work and the rest of your group's advanced knowledge in this field. It's quite amazing. Well, thank you so much, John, for joining us at this early hour in San Francisco, and we really appreciate you and look forward to hearing more about your research in the future years. Thanks so much. Have a good day.
Thank you, Ramesh, and thanks everyone for listening. And I think it's our group, Ramesh. It's our group that's going to do this.
Bye.